There will be lots laying how we will handle our Q&A session. At the end of our symposium, Dr. Amin will facilitate any questions that come in from our panelist presentations. If you are joining us on Zoom, if you look at the bottom of your screen, you will see that there is a Q&A tab. That is where we need you to put your questions. If you are joining us on Facebook Live or YouTube or Twitter, just put your question into the chat and we will move that into the Q&A session here on Zoom. And so with that, I will pass the baton to Dr. Amin, and he will start our symposium.
So thank you. Are you able to see my screen?
Yes.
Okay. So good morning, everybody, and thank you all for joining. It is indeed a pleasure to be collaborating with AIM Melanoma to present this symposium today. You know, folks who treated melanoma over the last 15 years have seen unprecedented change or impact on the outcomes in this rather dreaded disease. In the next couple of hours, the effort is going to be to kind of update everybody on how best to deal with it. Now here, what I'm trying to show you is what has happened to the incidence of melanoma over a period of last 10 years. So you can see in the graph that is on top, the incidence of melanoma has steadily increased over the last 10 years. But interestingly, what you can also see that the mortality over time has decreased. And this has largely come from development of multiple immunotherapy and targeted therapy agents listed out here and when they were approved. So there has clearly been impact of the therapeutics on the outcome of disease. And that is why we feel it is very appropriate that we now have in the caption, living with melanoma. So today, what we're going to be doing is we'll talk about a patient who has newly been diagnosed with melanoma and how best to deal with that. It is a time of great anxiety and confusion, and go through the continuum of the disease process and options. Dr. Atlas, my colleague, she is an assistant professor of medical oncology at Wake Forest and Atrium, and she will be touching on the toxicities associated with the melanoma treatments. My colleague from surgery, Dr. Malcolm Squires, assistant professor in surgical oncology, is going to update us regarding surgical management of melanoma in 2023. Jessica Davis is our PharmD, and you know, this is indeed an important aspect of management, and that is the financial toxicity of all these. These treatments are effective, but they can be horribly expensive. So she will update about that. And then Anne, as she alluded earlier, is going to provide us with some additional information and patient resources to tap into, and then we will have the Q&A session. So with that, let me start off with the patient perspective for melanoma. So I am at the Levine Cancer Institute in Charlotte. I'm the section chief for cutaneous malignancies, and I'm a medical oncologist. What I thought we would cover is new diagnosis of melanoma, what surgery to do that Dr. Squires is going to elaborate more. What is adjuvant treatment? What is neoadjuvant therapy, and when to consider that? If there is recurrence of disease, how to tackle that, what are the options for advanced disease, and Dr. Atlas is going to be elaborating more on that. And then just brief mention on the less common presentations of melanomas. Those are the mucosal melanomas and the ocular melanomas. So this is a continuum of disease as I see it. On the left side of this ongoing continuum is the early stage 1 disease, and then the late stage 1s, early stage 2s and 3s, and stage 2s and 3s that are more advanced, and then the recurrence in stage 4 disease. So the way I kind of try to present out here for better understanding is red is local. What we have are two modalities really, or two steps in which we manage disease. This is local control, that is either with surgery or radiation, and that is more important with the earlier stage of disease. I don't know if you can see my arrow kind of slashing through this. And then the systemic control, that is immunotherapy and targeted therapy. We sometimes use chemotherapy now, but not as often. And that is more for the stage 4 and the advanced disease. So that is kind of how we'll use the same diagram to go through different stages of disease. So let's start off with this 45-year-old gentleman who recalls having a mole on his left arm for a long time. And then over a period of 6 months, this became more prominent. It changed shape, it became flaky, and it became itchy. So those are the typical A, B, C, D, Es of melanoma. If there's a pigmented lesion or a mole that starts changing, it has irregular borders, it has irregular colors, the size is more than the diameter of the eraser on the pencil, and it is changing. So he did seek medical advice, a shave biopsy is done, and that showed melanoma. So now, all of a sudden, this is a diagnosis of potentially lethal outcomes, and what are we going to do with that? So the first step is to do risk assessment. So risk assessment is based on 3 factors: the tumor, the nodes, and we'll talk about that a little bit, and the metastasis. When we talk about malignancies, what it essentially means is that one of the normal cells became abnormal and started dividing without any control. And depending on where in the body that cell was, determines what kind of malignancy. So if that cell, this is a cross-section of the skin, so if that cell lived in the outer layer of the skin, and this cell is called a melanocyte that is darker in color because it contains a pigment called melanin, then it makes a melanoma. So if the melanoma or the tumor that you can see out here in the cross section, if it is confined to the skin only, then it is stage 1 or 2. And if it has traveled, the other characteristic of tumor cells is that they can travel, go elsewhere, and take new exits and make new colonies. So if they travel locally on side roads, and these side roads are called lymphatics, the little green channels that you see, and they're spread all over the body. And along these green channels, you see little immune system check stations, and these are called lymph nodes. So if they have traveled to the local lymph nodes, then it becomes stage 3. And if they decide to travel along the bloodstream, that is the highway system in the body, then all bets are off where they can go. So they can go to any organ system, and that's stage 4. So that is called distant metastasis. So in general, when we talk about the risk in early stage disease, it is dependent on 2 factors. The thickness, how thick the melanoma is. Look at this lesion on the top, and look at this lesion, how deeply it invades into the skin, and whether it is ulcerated or bleeding. So you can see this smaller lesion is not ulcerated, and the larger lesion has an area of bleeding or skin breakdown. So those are the things to be kept in mind in terms of risk assessment. Now, how do we manage that? So, earlier the melanoma, the thinner the melanoma, the lower risk the melanoma on the left side, local control can result in cure. It can translate into cure. So adequate surgery, and Dr. Squires will likely elaborate more on that. With adequate margins all around the primary lesion, can result in or translate into cure. In some instances, additional local control with radiation may need to be considered. So that WLE stands for wide local excision. Now, as the melanomas become deeper, remember thickness of the melanomas or ulceration or bleeding of the melanomas adds to the risk. Then we need to see if these cells have traveled elsewhere in the body. So now we need to find out if the local lymph nodes are involved, and that is by mapping out where is the flow of fluid from that area and isolating those lymph nodes. And then if it is a very high risk lesion and there are multiple lymph nodes involved, then the systemic control now becomes important, either before surgery, that is called neoadjuvant, or after surgery to reduce the risk of recurrence. And that is usually for a period of 1 year, either immunotherapy or targeted therapy. So in that continuum of management, what we saw was for the early stage 1 disease, wide local excision only is adequate. These are very thin melanomas without any high risk features. So local control translates into cure. For the late stage ones, so the little thicker melanomas, early stage 2s or 3s, now we do need to find out if they've traveled elsewhere. So the sentry or sentinel lymph node mapping would be warranted. And then depending on this, on the how risky they are, there would be consideration of systemic control for a year. For the late stage 2, that are really thick melanomas that are ulcerated, or the stage 3 melanomas that have spread to the local lymph nodes, we may need to, based on the stage, how risky it is, based on that, we may need to consider either neoadjuvant treatment, that means treatment prior to surgery, and we'll talk a little bit about that in a second, or definitely considered folks to reduce the risk of recurrence after their surgery with adjuvant treatment, that is immunotherapy or targeted therapy. So we've kind of dealt with the early stage disease that is confined to the skin or to the lymph nodes. Now, what is adjuvant treatment? And why do it? So this is treatment after the surgery is completed. So if everything is resected, if everything is already out, why should there be any further treatment? These are curves, and I don't want to belabor much, but I just want for you to see that these are folks who have stage 3 disease, and this is time in years on the bottom and melanoma-specific survival on the vertical axis. So higher the curve, more people alive, lower the curve, more people have mortality. So with stage 3, B, C, D disease, and again, we're not going to go into details of that, but higher the risk of disease, now that we have effective treatment options, there is adequate evidence to suggest that the risk of recurrence and death can be decreased. And this is the data for immunotherapy. Immunotherapy is, again, Dr. Atlas is probably going to be elaborating more, but this is using drugs that enhance the T cell activity and make the tumor environment more amenable to the tumor cells being killed by the T cells. The T cells are the guys that are part of the immune system that go and kill tumor cells. Again, on this graph, the horizontal line is time in months, and the vertical line is the relapse-free survival. All I want for you to kind of remember is that when we use immunotherapy, and that's this green line up here, the green curve, as opposed to an older immunotherapy, there is clearly a benefit for the newer immunotherapy with more folks being relapse-free at 5 years. 60 months is the 5-year time point. The same effect is observed if we use targeted therapy, and this is with BRAF and MEK inhibition, and we'll talk about a little bit about that. Some melanomas have a particular mutation, and that mutation can be targeted with oral agents and elicit responses. Again, the 60-month data, that is the 5-year data. This is time in months, and this is patients alive without any relapse on the vertical axis. The blue curve are the folks who got treatment, and the red curve is who did not. And again, there is clearly an advantage for getting treatment in terms of the 5-year relapse-free survival. So high-risk disease, consideration for 1 year of treatment after surgery is completed. Now, let's go to the next kind of stage where we're now talking about recurrence of disease. And that recurrence can be very local or limited, or it can be advanced, or it can be distant, which is stage 4 disease. So going back to our example, the patient got appropriate surgery initially. There was stage 1 disease, so all that was required was surgery. No adjuvant treatment was, so no immunotherapy or targeted therapy was needed. 5 years later, the gentleman presented with a little lump in that scar. So here's the scar, and here's that little recurrence. Scans were obtained and a biopsy done, and the biopsy showed this to be melanoma. So now, because this patient did not initially merit consideration for adjuvant systemic treatment with immunotherapy, now that this is a limited kind of recurrence, this can be taken off with local control using surgery, and then should be offered adjuvant treatment to reduce the risk of further recurrence. But sometimes the recurrences can be advanced. Same patient got the same surgery, stage 1 disease, was not treated with adjuvant immunotherapy up front or adjuvant targeted therapy. 5 years later, now presented with a lump under the armpit. Now, this is a PET scan. So this is the PET scan. We're looking at somebody from front to back. There are some areas in the PET that light up normally. So this is the brain that should light up, and that is normal. This is the right arm, this is the left arm, and under the left arm, there's this large area of activity. This is the right lung, left lung, and heart. So there's a large area of activity that we see under the left arm, and that is biopsied and is melanoma. Now, with that amount of tumor burden, there should be consideration for what is called neoadjuvant treatment. So what is neoadjuvant treatment? That is treatment before surgery is done. And the goal out here is to reduce the tumor size prior to surgery. That may decrease the morbidity of the surgery, and Dr. Squires may be elaborating on that later. It also importantly helps us tailor future treatments. So if we use for a limited period of time, say 6 weeks or 8 weeks, we use a modality, we use either immunotherapy or targeted therapy, then we can ascertain if this disease is going to be responsive to that treatment. Once the surgery is done and everything is resected, then doing treatment, there's no way for us to look at that at a pathologic or a microscopic level to see if that treatment has been effective. So this is the gentleman who got this recurrence under the left armpit. This is now the same gentleman who is lying on the table with feet towards us, and this is a cross section of the body at the level of the heart. So this is the right side because the feet are towards us. So this is the right side, this is the left side, and this is the armpit area on the left side. So he was treated with neoadjuvant treatment, and after 2 doses, the result is on the right in the right picture, where this lymph node diminished significantly in size. So that told us that this was a disease that was responding to immunotherapy, and this also made the surgery somewhat easier. When we looked at this under the microscope, this is on the left is the pathology from before surgery. Remember, in pathology in general, blue is bad. So if there's more blue in the picture, that means those are these abnormal, bizarre-looking cells. These are all melanoma cells. And this is the picture after, where he had a complete response. So it is all pink, so no disease was left behind. So that's neoadjuvant treatment. So for the recurrence, if it is local and limited, we resect the disease. If it is significant, then we will consider neoadjuvant treatment. If it is still not, if it is still localized to a region. Now, what if it is a distant recurrence? So if it is distant recurrence, now the tumor cells have traveled, and they've taken the highway system, that's the circulatory system, to travel, go elsewhere, take exits, and make new colonies. So now the role of local control at this point has become really none, barring a few exceptions. But really, it is all about systemic control, because this is once it's out of the bag, it can go anywhere. And there may only be some areas that show up on the scans. There may be other areas that we can't even see. So systemic control is with immunotherapy or targeted therapy. This is, remember we said the T cells, these are part of the immune system. The T cells are the guys that go out, seek out tumor cells by virtue of having this T cell receptor, this green kind of sensor, and they can potentially identify tumor cells as non-self or bad guys and kill them. So how do we harness the efficacy of these T cells? We found out that these T cells have on switches and off switches on their surface. And these switches can then be targeted. We can either turn on the on switches on this side. I just showed 3, but there are like tons of them. And or we can turn off the off switches. So one of the off switches is CTLA4, and a gentleman by the name of Jim Allison found out that by blocking that off switch, we can turn the T cell on. He did get the Nobel Prize for that, and he shared that with Tasuku Honjo, who figured out another off switch called PD-1, and blocking that can result in T cell not being turned off. So at present, we have three mechanisms and four medicines that are four immunotherapy medicines that are approved. Ipilimumab was the first one, also called Yervoy, that is an anti-CTLA-4 antibody. Off switch is turned off. Pembrolizumab or Keytruda, nivolumab or Opdivo block the PD-1 off switch and prevent the T cell from switching off. And relatlimab in combination with nivolumab, that is also called Opdualag, is the most recent in terms of the mechanisms. So all of them aim at activating the T cells to go and kill tumors. What is the efficacy? So this is data from the immunotherapy studies with ipilimumab and nivolumab. And again, this is time in months on the bottom and overall survival on the left. This is what the little crosses, the blue crosses represent what used to be the median survival for advanced melanoma, and that used to be about 6 to 9 months, the median being the 50% of the individuals were doing okay. So that used to be 6 to 9 months. That is now at 7.5 years is about close to 48%, 50%. And interesting to note that if we look at, this is the 36-month mark, if we enlarge that and look at those folks who did not have progression of disease by 36 months, they actually do remarkably well. So these are the survivals. It's at 95, 96% survival at 7.5 years for those folks who did not progress at the 36-month mark. Kind of alluding to cure. We also talked about targeted therapy. There are a whole bunch of different mechanisms in the body that result in signaling to the cell how and when to divide. This is one of those signaling pathways. Again, I'm not going to belabor, neither is there going to be a test on this material later on, but this is one of the targeting pathways that involves a protein called RAF. So it was found out that 50% of the melanomas have a mutation in the RAF gene, in the BRAF gene. Normally, the signaling should travel along these white arrows from RAS to RAF to MEK to ERK and then the nucleus. But if it is mutated, if the BRAF is mutated, and that's about 50% of the melanomas, then this cell becomes kind of goes on an auto-active schedule, does not require a coordinated signaling pathway, and continues to divide. So medicines, small molecules that were designed to block these links in the signaling pathway. These include the BRAF inhibitors and the MEK inhibitors. Now, using a combination of these BRAF and MEK inhibitors, again, this is the time on the bottom is time in months, and this is percentage alive on the vertical axis. The yellow dots represent what used to be that 6 to 9 month median survival, 50% survival, and that now with the combination of these oral medications is 1/3 of the folks are doing well at 5 years. So clearly, the earlier curves that we saw with improved survival are a result of these newer medicines. I'm just going to finish here. I just want to make folks aware that melanomas are not all in the skin. Skin is the largest organ in the body, so most of the melanocytes, they do live in the skin, but melanocytes can live in other sites in the body and can go out of control. This is on the left is an image of the brain with eyeballs. Again, somebody is lying with feet towards us. This is the right eyeball. We're looking at a cross section at the level of the eyeball. This is the nose in the middle. And you can see this mass growing inside the eyeball. These are ocular melanomas or choroidal melanomas. And on the right, this is a PET scan looking at somebody from one side to the other. So this is the front, this is the back, here's the spine. And what we see out here is an area of activity in the rectum, and this is these are the mucosal or the melanomas that involve the mucosal or the moist lining of body cavities. So these mucosal and choroidal melanomas behave somewhat differently compared to the skin or the cutaneous melanomas. They have slightly different mutations, and their management may need to be designed differently. So I don't know where we are with the time. I don't see that, but I will stop here, and I thank you for your attention. So I'm going to stop sharing my screen and introduce Dr. Jennifer Atlas, who is an assistant professor of oncology at Wake Forest as well as Atrium. And she is going to be updating us about some of the toxicities related to the treatments we discussed. Dr. Atlas.
Thank you for having me today. I'm going to pick up where Dr. Amin had kind of left off and speak to the toxicities associated with melanoma therapies and treatment. So the way I really divided this out was looking at our two big treatment modalities that we use most commonly. And that includes our immunotherapy agents that Dr. Amin spoke to, talking about anti-CTLA-4 antibody, anti-PD-1 antibodies, and our anti-LAG-3 antibodies, and have listed those agents as well. We also have 3 FDA-approved targeted therapy options that work at our BRAF and MEK locations, and those are listed here. So switching first to our immunotherapy toxicities. So picking up on our road system and talking about our T cell and our on-off switches that we talk a lot about in our clinic, we think about immunotherapy toxicity as us kind of letting loose that T cell. So we're taking it from being kind of a normal acting T cell at steady state. And the idea with immunotherapy is we're trying to turn the on switches on and the off switches, we're trying to kind of keep them from being inhibited with our drugs. So we're taking this immune response from kind of a cruising speed, and we're trying to kind of act within our speed limits that our body allows. So we're trying to manipulate and utilize our immune system that is already there to kind of do the work for us. The fall point here is when we do have some, and we're all kind of different. There's a lot of factors, hereditary, environmental exposures that can kind of affect our response and our immune response. If we exceed that speed limit that we have and go beyond our goal, we are not just attacking foreign kind of cells or cancer cells in that situation. We may be creating an autoimmune reaction that is affecting any of our good organs and cells. And that's the side effects that we're looking for. So inflammatory or injury type side effects to our various organ systems. So just as a general principles guideline to looking at kind of immune related adverse events and how we grade them and think about dose modifications. We're going to go through several important organ systems today, but grade 1, I generally think of as being asymptomatic or mild symptoms. Often we are continuing your immunotherapy during this. We're monitoring closely for any worsening of symptoms, and we're managing symptomatically. When we start to hit grade 2 symptoms, and our endocrine system may be separate from this, so that may be the exception to the rule here, treatment is generally going to be held and not resumed until we hit a grade 1 side effect or lower. And this is the point where in certain immune-related side effects, we may be thinking about starting oral steroids. Our grade 3 and grade 4 side effects are going to be our severe or potentially life-threatening grade or level of side effect. So immunotherapy is typically going to be permanently discontinued. We're often going to be giving oral steroids and sometimes additional immunosuppressive agents. And this is going to be tapered over several weeks typically. We may be also consulting other specialists to help, depending on the organ system involved. So immune-related adverse events, I've located several areas on the body here that we're looking for. The median onset is 2 to 16 weeks, but these can occur within a few days of starting therapy and can still happen up to a year after completion of therapy. Early toxicity most often presents as dermatologic side effects. With our anti-CTLA-4 antibody, so this was ipilimumab or Yervoy, we tend to see more dermatologic and gastrointestinal side effects. With our anti-PD-1 agents, these are pembrolizumab and nivolumab, we tend to think of our endocrinopathies, our rheumatologic side effects like arthralgias, joint pain and swelling, pneumonitis, which can be some breathing issues, and hepatic toxicities. The efficacy, so the impact of toxicity on the management of efficacy. This is a question that comes up often when we have to talk about interrupting therapy to treat our toxicities. Data suggests that the development of immune-related adverse events were associated with either improved efficacy of immunotherapy or similar efficacy when compared to those that did not experience these events, even when we did have to hold the immunotherapy. This suggests that immune-related adverse events represent a sign that the immune system is being activated with the drug that we've given and hopefully is additionally targeting the agent. So it's really important to remember, holding therapy does not mean that we are taking away your efficacy. And in fact, we may just be adding toxicity by trying to push through. So we have to think about this very differently than how we manage chemotherapy. What are some of the systemic or constitutional symptoms that we can see? Fatigue was one of the most important and common side effects that's reported and is subjective and different for all of us. It's important to exclude endocrinopathy, so effect on our endocrine glands, as part of the cause. Cytokine release syndrome is an uncommon side effect that we see, but it's an acute inflammatory response by having a robust response that can be characterized by fever with or without multi-organ dysfunction or injury. Infusion-related reactions are relatively rare for immunotherapy compared to some of our more traditional or older chemotherapies. They're often mild, and we generally are managing them with antihistamines, so agents such as Benadryl. What are some of the manifestations we can see when the skin is involved? Dermatologic toxicities. One of the most common things we can see is some pruritus, which is itching. This can occur in the presence or the absence of a skin rash. Usually involves the trunk and the lower extremities, and the median time to see this come on is after 3 treatments. Vitiligo is another thing we can see. This is characterized by some depigmented splotches or macules, usually located in sun-exposed areas. This is an example from our clinic of some patients that have experienced depigmentation in vitiligo, which is often something celebrated in our setting because it shows us that we're having that immune activation and hopefully also targeting those cancer cells. Some of the other manifestations we can see with skin-related toxicity, we can see inflammatory dermatitis or rashes. These can be maculopapular eruptions, eczema-type rashes, psoriasis-type rashes, and acneiform rashes or eruptions. We can see bullous pemphigoid or immunobullous diseases. This is usually characterized more by having vesicles. And there are some rare, severe cutaneous reactions that can be life-threatening, things such as Stevens-Johnson syndrome. This is an example of a patient who experienced an autoimmune inflammatory rash who went on to receive kind of appropriate toxicity management and resolution of that rash. So when we think about rashes, what is our grade 1 or our earliest kind of phase? We see symptoms that are not affecting the quality of life. We are often able to continue the immunotherapy and treat these symptomatically with antihistamines or topical steroid treatments. Grade 2 are symptoms that are affecting quality of life. We may consider holding treatment at this point. We're still doing antihistamines and topical therapy, but this may be the point in when we're initiating oral steroid treatment to help treat that rash. And grade 3, this is affecting our quality of life. We've had a lack of response to more conservative topical management. We are now initiating a more prolonged steroid taper and considering involving dermatology as well as holding the immunotherapy during this time frame. More severe grade 4 rashes that are not responding to steroids, we're now admitting potentially for IV steroids. We're discontinuing therapy potentially permanently in this situation, and we're having dermatology involvement. Gastrointestinal side effects. So when we break this up, we think about kind of our upper GI tract and our lower GI tract. Both can be affected. In the upper GI tract, looking from the esophagus down through the stomach and the small bowel, what sort of symptoms are we experiencing? Nausea typically and abdominal pain. When the lower GI tract, including the colon, is affected, our presentation is usually more defined by diarrhea, abdominal cramping, blood or mucus within the stools. How are we managing this? Well, first of all, we usually ask people to hold anti-diarrhea agents because this can mask diarrhea. It can prevent us from understanding what grade or severity of toxicity we're experiencing, and we're not actually addressing the underlying cause. So we think of grade 1 as being an increase of less than 4 stools from your baseline output daily. We're continuing treatment, but we are starting to make dietary modifications, adequate hydration. We're going to a bland diet, and we may be involving our GI colleagues if there's persistent symptoms. Grade 2, so now we're having an increase of 4 to 6 bowel movements beyond your normal baseline, changes in consistency, abdominal cramping. We're holding your immunotherapy, we're making dietary changes, we're ruling out infection with stool studies, we're getting GI involved because we need to think about imaging and we need to do an endoscopy to rule out kind of inflammation or ulceration along the GI tract. And if negative for infectious symptoms, this is the point where we're thinking about starting oral steroids for treatment. Grade 3, we're now having an increase of stools 7 or more beyond baseline. Hospitalizations indicated. We're having decreased oral intake. And so we're needing to hold treatment. If ipilimumab or CTLA-4 antibody is involved, that's usually permanent discontinuation at this level. We're admitting to the hospital. We're doing an endoscopy to look at the GI tract directly. We're allowing your bowel to rest, and we're giving you IV fluids and IV nutrition if needed. We're instituting IV steroids at this point, and this is typically going to be a course over several weeks of therapy. If you are not responding to steroids, we may need to think about other immunosuppressive agents that may be used, for instance, in inflammatory bowel diseases like Crohn's or ulcerative colitis. Grade 4 is life-threatening toxicity, so we take these very seriously. This is an example of someone who had an endoscopy who did have autoimmune colitis, and we can see kind of the red irritation and spottiness kind of throughout the colon here. When we think about kind of hepatotoxicity or involvement or injury, inflammation to the liver, what sort of symptoms are patients generally reporting? We're seeing fatigue, we're seeing decrease in kind of oral intake or anorexia, nausea, and we might be having some right upper quadrant, kind of right upper abdomen pain. In your laboratory studies, we're looking at your liver function tests and your bilirubin to kind of guide us as well. So once again, grade 1, this is going to be upper limits of normal kind of on labs, greater than and up to 3 times the upper limit of normal. Often we're able to monitor this and continue treatment. We're starting to avoid other agents that could be processed through the liver, such as alcohol, some of our cholesterol medications like statins and Tylenol. We're also continuing to follow your labs fairly closely once or twice a week to make sure that we're seeing stability or improvement. When we get to grade 2 levels of elevations in some of your liver function tests associated with some of these symptoms, we may be still asymptomatic, but we may be starting to see some of those symptoms I discussed kind of start to come to light. We'll hold treatment with immunotherapy. We'll avoid those agents also processed through the liver. We will be checking your liver enzymes now every couple of days to make sure stability, and we will be starting steroid at this time in oral form. Grade 3 level is now our liver enzymes are greater than 5 times, but less than 20 times kind of our lab's upper limit of normal. We're holding treatment. We're avoiding other agents through the liver. We're checking your liver enzymes daily. We are starting high-dose steroids. We're getting our liver specialist hepatologist involved, and we may be considering admission. If we're not seeing improvement with steroids alone in the first few days, we may be instituting additional immunosuppressive agents to help us. And if we have decompensated liver function, that's when we're discontinuing treatment. These are patients that are admitted and receiving high-dose steroids and other immunosuppressive agents. What happens in our lungs? We call this autoimmune pneumonitis, or inflammation in the lung or the lining around the lung. Grade 1 is going to be asymptomatic. This is a radiologic diagnosis, so us seeing changes on kind of imaging studies. We're going to typically hold treatment and monitor for improvement, and if we're not seeing improvement or worsening in symptoms, instituting oral steroids. Grade 2 pneumonitis, which would be presenting with shortness of breath or typically a dry cough that's persistent, we're going to hold your immunotherapy. We're going to think about getting a pulmonologist, a lung specialist involved. We're starting oral steroids, and we're monitoring both clinically and radiographically with additional imaging closely. Grade 3 is severe symptoms. This is limiting our activities of daily life. Oxygen may be required. Treatment is being permanently discontinued. We're admitting to the hospital. We are giving high-dose steroids in IV form, antibiotics if needed, and we're having pulmonary kind of take a look and actually do something called a bronchoscopy, which would be looking down through the lung airways. We may be also instituting additional medications from an immunosuppressive regimen to kind of help if steroids are not alone improving. This is an evidence or picture of the patient who was being treated, and you can see those red arrows going towards disease, and you can actually see across time the patient was improving in their actual melanoma, but you can see these haziness kind of come up along the periphery of the lungs, and that's what pneumonitis can look like, or inflammation in the lungs or lining around it to us when we're looking on CT scans. Switching gears to looking at our endocrine glands, there are several different glands that can be affected. Our thyroid, our pituitary, our adrenal glands, and our pancreas. In the thyroid, which is the one that's most commonly affected, we're checking your thyroid function with each infusion. So prior to each infusion, we're looking to try to detect changes before you may even develop symptoms. Presentation when people are developing symptoms may include fatigue, weakness, palpitations, that feeling of heart racing. When our thyroid is actually underactive, there's 2 levels that we're looking at. One's called TSH and one's called free T4. So when our thyroid's underactive, our TSH is actually elevated, and vice versa. When our thyroid's overactive, our TSH is actually decreased. So these are things we're looking for in your laboratory findings. Management often requires replacement of the thyroid hormone. Even if we have overstimulation and overproduction of the hormone initially, we often think about that as the immune system having a robust response, almost setting the production on fire, burns out eventually. So we need to monitor that closely, because in the upcoming weeks, we will probably see the function peter out or the production peter out, and ultimately still need thyroid replacement. Hypophysitis is looking at kind of inflammation of the pituitary gland. The pituitary makes a lot of different hormones, and when it is inflamed, you can have fatigue, you can have a headache across the forehead here. We think about it as being centered kind of behind the eyes there if we're having inflammation. Sometimes we can even see some changes in our peripheral vision, And we can overall have kind of generalized malaise type feeling. There's a number of levels of hormones in labs that we're looking at to determine, are these being underproduced? Management and how we detect this, we're looking at an MRI that we're asking them to do very thin cuts looking through at the pituitary. We want to make sure there's not been actual disease progression involving any of the brain tissue there. And we're also initiating steroids and trying to get taper down to the lowest dose needed to replace the hormones we're not making. The adrenal gland, if it is not operating or making its production of cortisol, which is our body's natural steroid that's released in stress, we may have a decrease in our blood pressure. It may present as dehydration. There may be electrolyte imbalances that we see. Once again, we're getting an endocrinologist, a specialist in this area, to be involved. We're hydrating, we're ruling out signs of infection, and we're starting steroids for treatment. And the pancreas can also be affected. There's a number of values we look at, like your amylase and lipase levels, but an uncommon side effect, but life-changing, that we always bring up is another important thing that's produced in the pancreas is insulin. If you're not making enough insulin, that's the definition of a diabetic. In this situation, when it's from immunotherapy, they typically are acting as a type 1 diabetic. So we're needing to monitor for glucose levels, get endocrinology involved. And if we have type 1 diabetes develop, that's usually insulin-dependent diabetes moving forward. Less than 1% of patients develop this, but once again, an important life-changing potential side effect. This is some of the labs I've summarized that we would look at. We would check an MRI if we were looking at the pituitary. And our management strategy for our endocrine glands is to institute steroids when needed, to taper as we can, and also the hormone replacement for whichever we are underproducing. This is a picture looking at your pituitary. So you can see pre-treatment in a patient, they've had ipilimumab in this particular situation, and you can see the swelling of this pituitary gland, and then post-steroids, how it's calmed down again. Looking through kind of our joints and rheumatologic side effects we can experience, we're looking for joint pain, swelling, muscle kind of soreness, inflammatory arthritis type features such as rheumatoid arthritis, and we can see the salivary glands start to underproduce and dry mouth. Grade 1 side effects we're thinking of as mild side effects. We're not interrupting treatment. We're giving symptomatic management, Tylenol, ibuprofen, things of that nature. Grade 2 side effects are going to be kind of moderate amounts of inflammation, joint swelling. They may be affecting our activities of daily life. We're holding treatment. We're starting steroids. We're giving symptomatic management for pain with Tylenol and like anti-inflammatories. And we're thinking about having rheumatology be involved. Severe side effects causing joint damage. At this point, we're giving oral or IV steroids as needed for the level of toxicity we're experiencing. We're having rheumatology involved, and there are some other biologic agents we can consider if steroids are not improving the symptoms. Myositis or myocarditis is the effects on the heart or the muscles. In this situation, this is very serious and can be a life-threatening side effect. We're looking for muscle weakness, muscle pain, soreness, chest pain, and shortness of breath. In grade 1, we're having just mild weakness. Grade 2, it's moderate weakness or abnormalities in their EKG or heart rhythm. And grade 3 and grade 4 can be life-threatening side effects. So when appropriate, we are holding therapy for early grades of side effects here. We're instituting steroids early. We're having the appropriate consultative services like cardiology, rheumatology, and neurology involved when needed. Nephrotoxicity is injury to the kidney or inflammation in the kidney. In this situation, this is very rare. We're following your creatinine levels, which is a reflection of your kidney function. And we're holding other agents that may be kind of stressing the kidneys, like anti-inflammatories. And when we get to grade 2 or higher, we're initiating steroids and having a nephrologist, a specialist involved. Neurologic toxicities are rare, but I wanted to mention them. These can present with fatigue, headaches, and we can see sensory or motor deficits. These typically develop within 3 months of initiation of therapy. We can see syndromes such as Guillain-Barré, myasthenia gravis, peripheral neuropathy. These are managed by neurology. We are having steroids involved, sometimes other endeavors like IVIG and plasmapheresis if steroid refractory. I wanted to shift gears and talk a little bit about some of the toxicities we can see in targeted therapy with BRAF and MEK inhibition. Shortly, I really quickly want to talk about the ocular toxicities. We can also see inflammation in the conjunctiva or the uvea, which are different areas within the eye. These can present, this is still with immunotherapy, blurred vision, double vision, or loss of vision. We need to have you assessed by ophthalmology. We need to consider topical steroids, eye drops in this situation, or if severe, we need to consider oral or IV steroids. Now, toxicities associated with targeted therapy with BRAF and MEK inhibitors. Some of the common, these are the 3 FDA-approved agents that were referenced earlier by Dr. Amin. Some of the constitutional symptoms that we can see that are most common: pyrexia references fevers. Management is typically immediately to hold the targeted therapy with the BRAF/MEK inhibitor, often for a short period of time. We consider dose reductions when patients are having very high fevers or fevers affecting their quality of life. We're managing with fluids, Tylenol, alternating with anti-inflammatories, and occasionally low-dose steroids. The highest incidence is seen with the combination of dabrafenib and trametinib. We can also see weakness and joint kind of pain. Dermatologic side effects, we can see the development of new non-melanoma skin cancers. This may include squamous cell carcinomas, keratoxanthomas. These are most common when we give either a BRAF or a MEK inhibitor by itself. We actually see decreased incidence when we give these 2 agents together. Rashes we can see can be some of these maculopapular kind of red raised bumps type rash, acneiform type rashes, most commonly associated with the MEK inhibitors, photosensitivity like a sunburn in areas, or hand-foot kind of rashes or syndromes. Cardiovascular toxicities, we are looking at cardiomyopathies in this situation, decreased pumping function or ejection fraction, prolongation of your QT interval, which we are watching on EKGs, and we're limiting medications that could also interact. Gastrointestinal and hepatic toxicities, we recommend withholding drug for grade 2 or higher, that's increase of 4 to 6 stools, or permanent discontinuation if this doesn't improve. We are watching your liver enzymes, and we may have to make dose adjustments in the setting of underlying liver disease. And last but not least, ocular toxicities, dry eyes, retinopathy, transient vision changes, or even retinal vein occlusion, which is uncommon but potentially very severe toxicity seen in less than 1% of patients. This does require urgent ophthalmology evaluation and interruption of drug. Thank you for your attention.
So thank you, Dr. Atlas. We will certainly have questions about this. So we'll wait for that. Let's find some time for those also. We're running a little bit behind. Next, I would like to introduce Dr. Squires. Do I see Dr. Squires here?
I'm here.
Oh, okay. Okay, there we go. Now I see you. So Dr. Squires is an assistant professor of surgical oncology at the Levine Cancer Institute and Wake Forest. He is a very active member of our melanoma team. Dr. Squires will update about the surgical aspects of dealing with melanoma.
Just as soon as I share my screen here. All right. Thank you, Dr. Amin, and thank you to the Aim at Melanoma Foundation for the chance to speak as part of this symposium this morning. I'm going to focus on the surgical management of melanoma. You've heard that alluded to a little bit in both of the talks thus far this morning. So objectives really to focus on the initial workup, again, which Dr. Amin had touched on of melanoma and the clinical staging thereof, and then to focus on the surgical management of the primary lesion as well as the regional nodal basins that we've discussed. And then when do we consider neoadjuvant therapy? What are some of the potential benefits? Touch on adjuvant therapy, which again, we've heard on. And then this notion of de-escalating surgery. So for someone presenting with an initial biopsy-proven melanoma, again, the T classification, when we're talking about the tumor, focuses on the Breslow depth or the thickness of that tumor as measured in tenths of millimeters. And that's really the most important data point from these biopsy pathology reports that we get typically from the dermatologist. And that depth, the Breslow thickness, translates to the T stage. And so broadly speaking, the T stage we think of as T1 is melanoma less than or equal to 1 millimeter, T2 is 1 to 2 millimeters, T3 lesions are 2 to 4 millimeters, and then T4 lesions are those thicker than 4 millimeters. When we're initially seeing a patient with a newly diagnosed melanoma, the physical exam can also give us some information that we use to further classify their stage of presentation beyond just that depth from the biopsy, including things such as satellite lesions or the regional nodal basins. So in the picture on the left, the primary lesion there is surrounded by additional cutaneous and what we call in-transit satellites. And then the lesion, the patient on screen right is presenting with an obvious bulge, golf ball sized lymph node in the armpit here. And both of those are important prognostic features as well as things that we factor into the staging of these patients. So the N or nodal classification is a little bit complicated, but it boils down to whether or not a patient has palpable or a clinically apparent lymphadenopathy or clinically obvious lymph nodes. For patients that do not, so all of those stages highlighted here, so stage 1 and stage 2, which again are determined by the thickness of the primary tumor, the skin lesion itself. Generally speaking, surgery first is the treatment of choice for those patients. And so what does that treatment entail? Generally speaking, the most important treatment is what's called a wide local excision, which we heard briefly about already. And that entails a margin negative resection or excision of the primary melanoma on the skin. And the margins for that lesion are something that is determined by the depth of the melanoma based on the biopsy. And so you can see here this diagram on the right, again, is sketching out the margins that we would map in order to ensure that we are excising every last bit of melanoma from the skin. Generally speaking, these are elliptical incisions so that we can ensure that patients have nice, well-healed linear scars when all is said and done. And again, the margins are a function of the depth of that tumor. So we've heard about sentinel lymph nodes briefly in Dr. Amin's talk. So when do we think about sampling these sentinel lymph nodes? And so that's generally for anyone that has a stage 1B, so a greater than 8 millimeter thick melanoma, or one with ulceration, or both. Those are the patients in which we would at least discuss and consider the sentinel lymph node biopsy. And that's largely a function of when do we think the risk of finding melanoma in that sentinel lymph node exceeds the risk of that complication. And so that's where we've derived these data from, is that for, again, any patients with a stage 1B or higher melanoma, typically the sentinel lymph node biopsy is recommended because this is an important staging tool. So while the sentinel lymph node biopsy itself has not been shown to improve the disease-specific survival, a positive sentinel lymph node is an important prognostic feature, and that, by definition, as we heard, upstages a patient to stage 3 melanoma. And those are the very patients in whom adjuvant therapy, the therapies that we just heard about, immunotherapy and targeted dual agent therapy, have been shown to improve recurrence-free and overall survival in appropriate stage 3 patients. So this is an important piece of prognostic information for patients and for medical oncology. So what does that sentinel lymph node biopsy entail? So again, as we briefly heard, we're trying to find the draining lymph node for that particular patch of skin where the melanoma arose. We do that by injecting a dye, typically 2 separate dyes. One of them is technetium, which is a nuclear medicine tagged dye that we can then take pictures of, what's called lymphoscintigraphy, to follow where that dye drains to, and it localizes to a lymph node and gives us mapping pictures such as those seen in the top left here. And sometimes we need more high-tech, higher resolution pictures such as the SPECT CT down on the right, particularly when we're dealing with melanoma on the head or neck. But this is the general sense in that we use a dye. And then the probe here shown in the top right is how intraoperatively we localize that lymph node. It's akin to a Geiger counter is the analogy I use, that allows us to localize the specific lymph node that drains that particular area where the melanoma arose on the skin. We also typically will use a second dye, a blue dye that's injected in the operating room once the patient is asleep, that again serves the same purpose. It travels through the lymphatic channels from the site of the primary melanoma to the draining sentinel lymph node and is a visual cue. So the lymph node literally stains blue once that dye travels through the lymphatics and lodges in the sentinel lymph node, and that allows us to again reliably locate and remove that sentinel lymph node. So again, the sentinel lymph node is important for determining potential next steps in treatment. It gives us important information for the prognosis, and it has been shown to be associated with improved recurrence-free survival or regional control, but not necessarily disease-specific survival. So one question that sometimes comes up is, what about this notion of genetic testing or genetic expression profiling? And I think the short answer to that is that that notion of using genetic tests that could be potentially done on the tumor itself or on the biopsy is not quite ready for prime time. And it's something that potentially down the road could be much more useful as we learn more about it and have more robust data. But as of now, that's generally not something that can replace the role of the sentinel lymph node biopsy in staging and managing our patients. So what if the sentinel lymph node does in fact show that the melanoma has traveled to this first pit stop? So historically, up until 2017, really, the recommendation for any patient that had a positive sentinel lymph node was that the next step should be what's called a completion lymph node dissection, or a much bigger surgery to go in and remove all of the draining lymph nodes in that area, typically the armpit or the axilla or the groin or the inguinal lymph node basin, or for, again, head and neck cancers, typically a modified radical neck dissection to remove all of the lymph nodes in that area under the presumption that there could be melanoma in those additional lymph nodes. Now, those lymph node dissections can be quite morbid. Thankfully, these complications are rare, but what I'm illustrating here in these pictures are some of the most severe examples. So lymph node dissections, again, these more extensive surgeries where we're removing all of the draining lymph nodes, there's a much higher risk of wound complications. There's a higher risk of things like a blood clot or DVT, much higher risks of things like numbness and paresthesias, because some of the sensory nerves can be affected. And again, more drastically, lymphedema is one of the most dreaded concerns and side effects of these bigger lymph node dissections, which can be really morbid and potentially lifelong. So just to highlight this trial that came out in 2017, which is referred to as the MSLT2 trial, this was a landmark study that's really changed the way in which we manage patients with positive sentinel lymph nodes. So this trial looked at nearly 2,000 patients who had positive sentinel lymph nodes and randomized them to the lymph node dissection surgery that we just discussed versus observation. We found, importantly, that only 11% of the patients that were randomized to the full lymph node dissection actually had additional melanoma in the lymph nodes that were removed. And importantly, the 3-year melanoma-specific survival was no different in these two groups, and that this plot off to the right illustrates that by and large, patients did equally well, whether we took them to this much bigger surgery, which again entails significant risk of perioperative complications, versus observation alone. And the morbidity, again, was significantly higher, not surprisingly, in the patients that underwent lymph node dissection surgery. So now in 2023, for patients that have a positive sentinel lymph node, the options are observation without additional lymph node surgery, in which case we typically closely monitor the draining lymph node basin with ultrasound to look for any signs over time of additional lymph node involvement, or completion lymph node dissection. And there are specific situations in which surveillance or observation may not be feasible, because there certainly is a risk of recurrence in the additional lymph nodes over time. And so again, for patients in whom observation and that close surveillance may not be feasible, or if there are things based on the tumor itself or based on the sentinel lymph node that suggest a higher likelihood of regional lymph node involvement, then potentially we would recommend lymph node dissection. Or in patients in whom adjuvant therapy or systemic immunotherapy or targeted therapy after surgery would not be feasible, then again, surgery may still play a role. But as we heard from Dr. Amin and Dr. Atlas, the development of these systemic therapies has been truly a game changer for our patient population. So why is staging so important? And we saw this figure briefly earlier, and this just shows the survival separated based on the different stages. And not surprisingly, from top to bottom, the lower stage disease in pink and green at the top, those patients do remarkably well over time. And patients with stage 2 disease, shown in orange and blue and brown, again from progressively lower to higher stages, top to bottom, still do relatively well, but certainly have a higher risk of their melanoma coming back and of ultimately succumbing to that disease. Apologies, screen is appearing to have frozen here. Okay, so this again is showing just the stage 3 patients again, and you see separation of these curves suggesting that patients with more lymph nodes involved do worse, and those with thicker melanomas do worse. Something of interest here, again, on the left is stage 1 and 2 disease, and on the right is stage 3 disease. Again, those patients with positive lymph nodes classified as stage 3. But what jumps out is that some of the patients with these stage 2B and 2C melanoma actually seem to do worse than those with stage 3A disease, for whom the 5 and 10-year melanoma specific survival is actually still quite good. And so patients that are eligible for adjuvant therapy, again, these systemic therapies after their surgery, we've expanded to include not only the patients with stage 3 melanoma, but in certain cases, patients with stage 2B and 2C, who again, their risk of recurrence may actually be higher than those patients with stage 3A disease. So we've expanded the patient population that we're sometimes looking at offering these adjuvant therapies to, again, with the goal being to try to do everything we can to reduce the risk of recurrence and improve survival outcomes for these patients. So briefly, what about neoadjuvant treatment, which again, we've mentioned earlier, defined as treatment before surgery, these systemic therapy options with the plan to ultimately proceed with surgery, but treating with several cycles of one of these agents or a combination of these agents before surgery. So why might we consider that? Some of the potential benefits are to downstage disease, meaning potentially make surgery easier or less disfiguring. It gives us potentially very valuable prognostic information about the benefit, how well a patient's tumor responds to that therapy. In some patients, it eliminates unnecessary surgery in a patient whose disease might rapidly progress. We want to avoid surgery, frankly, in somebody whose disease is not going to be helped by a potentially large operation if they're going to progress within a matter of weeks to months of that surgery. Potentially eliminates the need for things like adjuvant radiation, and it may improve recurrence-free survival. So similar to some of the figures that Dr. Amin actually showed, this is a different patient, but this is a CT scan of a patient with a large axillary lymph node. So a lymph node metastasis at presentation in their armpit here. And after just 6 weeks of targeted therapy, you can see the dramatic decrease in the size of this lymph node, making surgery possible and certainly much safer. And the odds of doing a margin negative complete lymph node dissection are significantly improved by just 6 weeks of therapy. So this provides valuable prognostic information in that when we follow up this neoadjuvant therapy with surgery and we look at the response in the lymph nodes that we remove, patients in whom they've had a pathologic response shown in blue do much, much better over time than those patients shown in red that did not have any response in their tumor when we looked at these under the microscope after surgery. Restaging after neoadjuvant treatment, again, even just a few cycles or a few weeks, can identify patients who are having progression of their disease in whom surgery would not be helpful. This is obviously a scenario that we hate and don't like to see, but again, surgery is not going to be the answer in a patient whose disease progresses from just a single area at presentation on the PET scan shown on the left in column A, but after just a few cycles of neoadjuvant therapy, you can see that their disease has progressed in multiple sites and surgery is no longer going to help that patient. Again, it can potentially eliminate the need for us to lean on things like adjuvant radiation, and if we can see a dramatic response in the number of lymph nodes or the size of lymph nodes involved, which are typically features that we use to decide on whether or not radiation therapy is going to be helpful. This was a landmark trial, again, to speak to this notion of neoadjuvant therapy and the potential benefits of that. So this was looking at patients with advanced disease, stage 3 or stage 4 resectable melanoma, and comparing patients who received neoadjuvant, so again, before surgery, followed by additional therapy, versus patients that got surgery and then adjuvant or after surgery. And so the patients in blue, those patients that got a portion of their therapy before their surgery, did remarkably better than those patients that got their systemic therapy only after surgery. And there's multiple theories as to why that might be happening, but these are fairly remarkable data that we're seeing here, and other trials have borne that out as well. And so just briefly to finish up talking about this notion of de-escalating surgery, there's been published studies looking at potentially just removing the single involved lymph node, as is often the case in patients that may only have a single palpable lymph node. The surgery for that patient historically has been a completion lymph node dissection, or removing all of the lymph nodes in that draining area, under the presumption that potentially other lymph nodes could be microscopically involved. So this was a small study just looking at 82 patients with clinically palpable lymph nodes, so nodes that we could feel on presentation, who underwent 6 weeks of neoadjuvant therapy before their surgery, and then went on to have their completion lymph node dissection. And what we found is that in almost all patients, the response in the index node, the clinically palpable node that we knew of at diagnosis, mirrored the response in those remaining lymph nodes. And we're looking at this further in prospective trials now. I briefly just wanted to touch on the Prado trial, which again looked at patients with stage 3 disease, those who had clinically palpable lymph node involvement at presentation. Nearly 100 patients who received 6 weeks of neoadjuvant therapy before their surgery, and then the index lymph node was removed and evaluated. And then from there, patients were sorted into 3 different pathways based on their response in that lymph node. So patients that had a major pathologic response, meaning less than 10% of the tumor in that lymph node was alive and viable, they did not go on to get surgery, and they did not get adjuvant therapy. Patients that had a partial response, meaning 10 to 50% of the tumor was still alive in the lymph node that was removed, they went on to get a lymph node dissection, no adjuvant therapy. And those patients that did not have a response, or had more than 50% of their cancer still active, went on to lymph node dissection as well as adjuvant therapy. And importantly, in those patients, the subset of patients who had a major pathologic response, which was over half in this small trial, we could avoid the lymph node dissection surgery in that patient population. And these folks did remarkably well at short interval follow-up, with nearly 93% of those folks relapse-free at 2 years, as opposed to those patients that had non-response, or greater than 50% of their tumor still alive. They had significantly lower recurrence-free and metastasis-free survival. Again, it's short follow-up at just 2 years. But all of this speaking to potentially, as these data become more mature and we study this further, we may be able to quote unquote de-escalate or potentially avoid surgery in patients who we know have had a response to immunotherapy. And again, this has been a complete game changer for these patients. So I'll stop there, and we'll be happy to answer questions at the end of the symposium.
So thank you, Dr. Squires, for that excellent overview. I'm sure I know that we already have some questions that we would need for you to address. And then let's move on to Jessica Davis, who is our PharmD. She's going to talk about the financial toxicity involved with some of these new treatments that can be quite considerable. So Jessica.
Thank you, Dr. Amin. So we're going to switch gears, in talking about how we can treat melanoma and some of the toxicities, and talk about some financial ramifications. Just a disclosure, I am not a financial coordinator or an insurance expert, so a lot of what we're talking today is based on data that we do have available and kind of our experience with our patients. So we're going to define what financial toxicity is and talk about implications specifically for patients with melanoma, and then importantly, think about ways that we can reduce financial toxicity. So we heard a lot about how we treat patients with melanoma. We think about the cost of surgery, the cost of treatment, radiation potentially, as well as scans, but other things that we have to think about include time off work, as well as other costs associated with care like transportation. Since I am a pharmacist, we're going to spend a lot of time talking about the cost of treatment related to medications, but certainly other parts of care do, contribute to financial toxicity. So what do I mean when I say financial toxicity? So we're specifically talking about the financial or economic burden associated with having cancer. So this can specifically be material hardships like direct out-of-pocket expenses, but we also need to think about what that means psychologically, such as the anxiety or worry about paying for all of this, as well as different coping mechanisms like spending less on food so that you're able to afford medications. About half of patients who either currently have cancer or are survivors of cancer have some type of financial toxicity, and it is more common in our patients with lower socioeconomical status. It can be associated with different racial or ethnic minority groups, as well as our younger patients. One trial that looked specifically at financial toxicity in patients with melanoma sought to report financial toxicity in patients with melanoma who received immunotherapy, as well as describing the association of financial toxicity with quality of life. So this was a cross-sectional survey, again, of patients with melanoma that received an immune checkpoint inhibitor, and they looked at a specific comprehensive score and measured quality of life using a particular survey that has been validated. The cost scores are reported here, but I think importantly, we found that younger patients, so those less than 65 years of age, reported higher financial toxicity and more financial difficulties. And financial toxicity was significantly correlated with global quality of life. So really what we're learning is that patients and providers need to address these questions about cost and concerns of our patients. And so we're going to take a deeper dive into how we can do these things. There's also some data to indicate that financial toxicity is not limited to the patient itself, which I think makes a lot of sense. Our families and caregivers are important in caring for our patients. And so we know that the cost of cancer care affects family members as well as the patients themselves. Parental cancer history is associated with increased economic risks for minor children. So we have increased worries about food running out, paying monthly bills such as rent and things like that. And we also have data to show that we do have increased financial burden on family members of patients with cancer, which probably doesn't surprise a lot of people listening to this. We do need more research to kind of characterize and also help us determine how to relieve some of this burden on our families and caregivers. Now, I wanted to take a minute to talk about the actual cost of some of these drugs. So thinking about immunotherapy, we learned a lot about how we can use immunotherapy in the treatment of melanoma, but it's also being used in other types of cancer. And you can see the graph on the left that we're really seeing a significant increase in market size for these types of medications. This graph is in billions of dollars. And so I think that really just shows how much these cost. The cost to each particular patient does depend on the insurance plan. Medicare, typically these are billed through Part B, and typically our patients have a 20% deductible. So they're paying 20% of the cost of the medications, which can be significant because these types of medications do have a high cost. Often supplemental insurance will help cover that 20%. Commercial insurance really varies by plan, and it is typically based on the deductible and maximum out of pocket, so that can be a little bit harder to predict. Oral targeted therapy, like the BRAF/MEK inhibitors that we talked about, are also very expensive. However, these differ from the immunotherapy agents because these are billed through the prescription drug coverage plan. So for our Medicare patients, this is Part D. Typically, the Medicare plans require patients to pay a percentage of the drug's price. So usually 25%, but again, that does vary on the plan. So if we take an example of one of these medications, the cost of dabrafenib is approximately $10,000. So if you're looking at paying 25% of that, that's still over $2,500 per month, which is just not feasible. Other types of insurance plans may have a set copay, so it may be a little bit more affordable, but again, it does depend on the specific plan. So how do we help our patients cover some of these costs? We need to think about the healthcare system in general, the responsibility to providers, but also the responsibility of our patients. And so we're going to take a deeper dive into what we can do at each of these levels throughout the healthcare system. One thing that we've tried to do is screen patients for financial burden and kind of what their financial difficulties might be. We try to do this routinely, but we don't know exactly what time points we should routinely screen or what specific questions to ask to help better understand what our patients are experiencing. We also try to assess for health insurance, but sometimes it can be hard to determine if our patients have insurance, but it doesn't cover the cost, so they're considered underinsured. It's sometimes hard to determine that. And then how does screening translate into actions to actually address these financial needs? Sometimes there's a gap in this. We can use financial navigation to help guide our patients through various aspects of care. This can be through a social worker, a nurse navigator, pharmacy or medication assistants, things like that. And these people can really assess financial needs and hopefully guide patients to appropriate resources. One example that I wanted to look at was in a leukemia clinic, but they instigated screening for patients who are being treated in their clinic. And patients who had a negative screen, meaning they weren't necessarily having financial burden or financial toxicity at that time, were put into a standard of care arm. But patients who had a positive screen were put into the intervention arm, where they were automatically connected with a financial counselor, a social worker, and a pharmacist. The social worker helped with costs such as grants, transportation, and household costs, and the pharmacist helped with medication cost saving strategies. And overall, you can see the costs that these interventions were able to help with. So social work was able to provide a median of $850 per patient, whereas the pharmacists or pharmacy technicians were able to help with almost $200,000 savings per patient associated with medication costs. Sorry, my screen froze. So some strategies to help with medication costs include copay cards, which may be available through the pharmaceutical manufacturers. However, these are not able to be used for our government-funded insurances like Medicare or Medicaid. Patient assistance programs are also available. These are typically what we think about with the manufacturers providing free drug to our patients. These are available for all insurance types or patients with no insurance, but it is income-based. So occasionally I will have patients that make too much income to qualify for this type of assistance. And then there are other grants that are available through foundations or other sources, but again, these are typically income-based. I wanted to give you just an example of what this looks like based on different manufacturers. So I have the manufacturer or assistance program on the left, and then what copay assistance looks like for our commercial insurance, and then providing free drug for patients who qualify for patient assistance. So you can see typically for copay assistance, patients are looking at somewhere between $0 to $25 copays per month up to a certain maximum. So again, just an example for you to be able to reference what I'm talking about. There are also a couple of other assistance and reimbursement websites out there, including Needy Meds, that can help us determine what other options might be available for our patients. So when I think about the responsibility or what type of questions we can ask from our perspective as the provider, I think about what type of job roles or responsibilities our patients have and what type of limitations this might have based on the treatment, side effects, and cancer-related symptoms. We can talk about different treatment options and some of the benefits that might be for taking oral medications versus IV therapy. Of course, we want to offer the most efficacious treatment for our patients, but sometimes it can, make a big difference for our patients if they're receiving IV versus oral treatments. We can also think about extended interval dosing so we can have potentially less frequent infusions to help our patients. And then we also talk with our patients about goals of care. Are we trying to do aggressive treatment, or are we moving more towards best supportive care, as this can also help us think about the cost of some of these different treatment options. I think overall we're more aware of different solutions. Our group does have a financial toxicity tumor board where we discuss challenging cases or different opportunities for providing financial assistance. And this is just an example of what we've been doing from kind of a provider and healthcare system to help our patients. So some institutions do have specific processes such as social works or nurse navigators, specialty pharmacy, and financial counselors to help our patients. And then just being aware of other options that you can refer patients to, such as grants or patient assistance programs. I also wanted to spend just a minute talking about the Mark Cuban Cost Plus Drug Company, as I've heard a little bit more about this in the past few months. So for those of you who might not know, this Mark Cuban Cost Plus Drug Company provides affordable generic medications to patients who are either uninsured or underinsured. And they set their costs based on the actual cost of obtaining the medication with a 15% markup and a $5 shipping fee. So I have some examples here. On the left are all current cancer medications that are available through this program. I've highlighted two that may potentially apply to our melanoma patients. So imatinib we can use in patients who have a particular mutation called c-KIT. And then temozolomide is an oral chemotherapy that we can sometimes use for our patients. So you can see the significant improvement in cost from the retail price versus through this program. And then I have a list of other common medications that our patients might be prescribed as well, just again as some examples for you to reference. So this could be potentially be an option for assistance for some of our patients. So you might be thinking, I thought generic medications were supposed to be cheaper. So one study sought to look at the potential savings for Medicare Part D plans, looking at using this Mark Cuban drug plan of 7 oncology drugs. And there was a potential savings of $661 million with a range there based on the particular Part D plans that were included. And so I think that just really speaks to, although yes, generic medications are typically cheaper, there is still some benefit to looking into other options rather than using insurance plans alone. So we've talked about some options from a healthcare system perspective, from a provider perspective, but what about the patients? I think it's really important that we emphasize the importance of discussing concerns with the healthcare team. I know we're trying to ask more questions and screening patients, but we don't know if there's a problem if our patients don't talk to us. I know that there are barriers related to reluctance. Sometimes cultural differences play a part, or if you're meeting a new provider, sometimes you don't have that trust in the relationship yet. But it is important to provide as much notice as possible when insurance changes are anticipated so that we can make sure that you're staying on treatment and there are no gaps in care. Sometimes we have access to different programs through the institution that can help cover those gaps in insurance. You might be asked to provide documentation when needed. Sometimes income or tax paperwork is required for assistance. And then always, please ask us questions. Again, we don't know if there's a problem unless you ask or tell us. And so we're always happy to either answer questions or direct you to those who can assist more if we ourselves don't know the answers. So overall, we know that financial toxicity will affect a large percentage of our patients, including patients with melanoma. We can implement solutions at a health system, provider, and patient level, but most importantly, I think it's important for us and for our patients to know that there are options out there for medication assistance, and these can include grants, manufacturer assistance, and copay cards, among others. So really just knowing that these options exist and when to ask for help, I think is really key. I know that was relatively quick, but again, I'm happy to answer questions. And I will stop sharing my screen now for the next section.
So thank you, Jessica. That I'm sure I already see some questions coming in for you. So we need to get to those. But let's get Anne back, and Anne, if you can provide some of the resources that are useful for our folks.
Thank you, Dr. Amin. I know that everyone is anxious to hear more, to hear the answers to the questions. We have several, and I thank you for this opportunity to talk a little bit about AIM at melanoma. I'm sorry, I think I'm sharing the wrong thing. Let's see what's happening. Just a moment. I need to stop my share and pull up my PowerPoint. Okay, let's see. Okay, let's see if I can do it again. I apologize. All right, here we go. I want to see. Is this it? Did I share the right thing? No, I did not. I'm sorry. I'm usually much, much better than this. Okay, here we go. All righty. And here we go. Do you see my PowerPoint?
Yes.
Okay, you can see my PowerPoint?
But you want to put it in presentation
Yeah,
mode?
I do. I apologize. I don't know what happened. Here we go. And I need to get it in. Let's see, I need to pull this down so I can see what I'm doing. And there we go. There we go. Okay. Thank you for your patience with that. For those who are not aware of AIM's story, our origin story begins with Charlie Guild's diagnosis with melanoma at the age of 26. After she passed away, her mother, Val Guild, formed AIM at melanoma. Since that time, our mission has been to fund research to fund a cure for melanoma, but also to support people who are living with melanoma, because and that comes largely in the form of education, because we believe that informed patients are better able to participate in their own care, and as a result of that, oftentimes will have better results. So that begins with our website. We would like to direct you to our website for information rather than going to Dr. Google. It is very intentionally filled with current and relevant information. It is soup to nuts, and I just want to tell you a little bit about the information that is available on our website. Our most frequently visited web pages for sure are on staging and related treatments, and also on side effect management. And I want to thank Dr. Atlas for her excellent presentation on that today. We have a brand new section on our website dedicated to clinical trials, including information on a clinical trials matching service. And for our visual learners, we have Melanoma 101 websites so that you can familiarize yourself with some of the testing and treatment. What does it mean to be BRAF positive? Those kinds of things. Those webinars are hosted by Melissa Wilson. She is also the individual who we have a program called Talk to a Medical Expert. We have a form on our website that you can fill out. Her role is not to change your treatment, but rather to make sure that you understand the treatment that is being suggested by your care team. As a result of doing that for several years, she's developed a webinar series called From the Clinic to the Living Room. She's taken her most frequently asked questions and made webinar videos on those. And so I direct you to those because they are absolutely excellent. Our symposiums, we have 10 of those a year. We co-host those with a variety of cancer clinics across the country. At the end, as with today's presentations, they will be edited, divided by topic, and then placed on our website for people to view throughout the year. So I direct you back to our website to see some of the presentations that we have from the various symposiums that we've done over the years. And lastly, we have a podcast which is hosted by Ray Liu, who is an oncologist with Kaiser Permanente. Our podcast is called Beyond the Clinic. It touches on some of the topics that might not typically be covered inside the clinic. We talk about things like building a support circle, managing anxiety, sun safety, things like that. These are all very excellent. And again, I direct you to our website to check those out. And lastly, I want to take just a second to talk with you about our one-on-one peer support program called Peer Connect. We have recruited volunteers who are on the other side of treatment. So they are former melanoma patients. They've completed a training program so that they can serve as mentors. They are more than willing to offer advice and empathy to newly diagnosed patients about the myriads of ways that their lives are being affected by their cancer treatment. They are a source of one-on-one support, a listening ear, and guidance in a safe, non-judgmental, and confidential environment. And lastly, I do want to add to this that we have a webpage called Helpful Organizations. And on that, we do have a link to financial organizations that specifically exist to work with cancer patients to navigate the cost of cancer. And so thank you, Dr. Davis, for your excellent presentation. And I would like to point people to that page as well. I am more than happy to help our listeners navigate to those resources. You can do that either by going directly to our website, or you can reach out to me at ann@aim@melanoma.org, and I will help you find any of the resources that I have mentioned. And with that, I will stop sharing and pass the baton back to Dr. Amin so that we can now have our question and answer session.
Thank you, Anne. And I've tried to address some of the questions that appear to be specific, but there are some questions that I think would be of value for everybody to share. So the first question is there any reason I would not want to ask for neoadjuvant immunotherapy instead of just adjuvant? And I can take that. So at this point, the neoadjuvant therapy it requires certain guidelines to be fulfilled, and that means that the disease has to be advanced enough that it is easily evaluable or measurable. If it is non-evaluable or non-measurable, very tiny melanoma, then those folks are at this point not candidates for neoadjuvant immunotherapy. It would only be for those with locally advanced presentations, large primary lesions with ulceration or palpable lymph nodes or in-transit disease. So I trust that answers that. The next is a surgical question. So I'm going to ask Dr. Squires to to address this. The question is, my father was just diagnosed with melanoma. He is in his mid-80s. He is being scheduled for a lymph node biopsy, but I have concerns. What do you recommend?
So without knowing the particulars of that case, I would say anytime we're weighing whether or not to proceed with a sentinel lymph node biopsy, we're balancing the risk of the general anesthesia that's required for a sentinel lymph node biopsy. Whereas oftentimes, if we're just doing a wide local excision of the primary melanoma itself, that's something that we routinely do in the office with just local anesthetic. But balancing that versus what we think the likelihood of finding a positive sentinel lymph node would be and the implications of that. So a healthy 80-year-old in whom we might consider doing additional treatment were we to find a sentinel lymph node biopsy, and a healthy 80-year-old who could tolerate general anesthesia with reasonable risk, I think that very well could make sense. An 80-year-old with significant other medical problems and whom we might not even be able to act upon the information of a positive sentinel lymph node, I think that's very much a situation where, we might forego the sentinel lymph node biopsy and the general anesthesia that's required. So I think there's some nuance to that, but again, balancing the risk of finding a positive node and whether we'd be able to treat with additional things versus general anesthesia.
So age per se is not a contraindication. It's the physiologic age rather than the chronologic age that would decide.
I would agree, absolutely.
Okay. The next question, I believe, is geared to Dr. Atlas. So at stage 3, immune treatment usually takes how long? The side effect of immune treatment makes the quality of life low, fatigue, weakness, dizzy, fever, etc.
So stage 3 treatment with these drugs typically lasts 1 year, whether we're using immunotherapy or targeted therapy for stage 3. As we discussed kind of during my initial slides, the median time to onset, we can have side effects after a single dose, although that's uncommon. It typically starts to emerge after a few cycles of therapy or infusion. That being said, there are some patients that make it through an entire year with immunotherapy or targeted therapy with relatively few side effects, and some that experience those in greater severity. So if someone is having kind of toxicities that are limiting their quality of life or activities of daily life, that's when we really have to have a conversation, patient, family, provider, team, to decide, especially for immunotherapy and targeted therapy, does everyone need to get that, full year? Our immune systems act differently. We have difference in kind of robustness of response. And so it's about kind of garnering that activity in the immune system. And so for some people, the right choice is that we do have to make modifications in the time we stay on, and hopefully are mitigating those side effects as much as possible.
So I hope that kind of addresses the concerns with the side effects. There's a question about, can you provide support group information? I believe both Jessica and Anne did provide that. Also, what groups help when, if insurance lapses due to not being able to work or costs are extensive due to travel to seek treatment. So I trust this has been answered. But again, kindly refer to the AMET Melanoma website, and I believe these resources that Jessica mentioned will be available online. So let's go to the next one. Now, this may be more so for Dr. Squires. If melanoma is found during pre-surgery scan and biopsy confirms melanoma, what determines total dissection versus only removing the node known to contain melanoma? Total dissection showed melanoma only in one node. Patient shows no evidence of disease post wide local excision and total dissection, but opted for a year of adjuvant therapy as preventative to recurrence. How much does this increase the survival rate for the patient? So I think it's a two-pronged thing. Part of it refers to the surgical aspect and some to the benefit from immunotherapy.
So with regard to the first part of that question, again, without knowing the specifics, generally speaking, it sounds like referring to a stage 3 patient, so someone who has lymph node biopsy confirmed melanoma. The standard of care as of now still typically remains total lymph node dissection, so removing all of the lymph nodes from that involved basin. As we saw from some of the data that I presented, it's not uncommon, though, in that scenario that we don't find additional melanoma in other lymph nodes beyond the one that had already been biopsied. And so that speaks to this whole notion of, can we possibly de-escalate and do less surgery for specific patients in the setting of getting neoadjuvant therapy and assessing that response? I would say those are all areas of active ongoing investigation and prospective trials that we don't know the answers to that. So I think the scenario outlined is the standard of care for the patient in this question. And then I'll let you address, the notion of receiving a year of adjuvant therapy. That would be standard of care as well.
Yes, so that would be, and it would depend on the assessed risk as we kind of looked at those graphs earlier on. Stage 3A would have a lymph node positive. Stage 3D also has lymph nodes positive, but their risk for recurrence in melanoma-specific mortality is very different. So the benefit that you can get from the systemic adjuvant immunotherapy is proportional to the actual risk. So somebody who has stage 3A disease would have very little benefit. So normally we don't even offer adjuvant systemic therapy for stage 3A disease. Those folks who have stage 3B, 3C, or 3D disease, 3D, the 10-year survival is 25%. So yes, those folks will be offered, and at this point we have a benefit in terms of the relapse-free survival with these newer medicines. An earlier study with ipilimumab had shown a 10% improvement in overall survival compared to placebo. So that is the benefit, but the benefit is proportional to the risk. Dr. Atlas, there's a question coming in for you. Will steroids for serious side effects counteract the immunotherapy a significant amount?
So one of the things I referenced is that getting treatment and having an activation that requires you to actually go on steroids, there's some data now that kind of indicates that activating the immune system to the point of having side effects is maybe showing us that hopefully it's treating the cancer as well. And taking steroids to treat that side effect does not necessarily diminish your chances of efficacy compared to those who do not have to be treated for a side effect. That being said, the caveat I would say is that our clinical trials for immunotherapy specifically, one of the eligibility to go on to trial was patients being at a dose of prednisone 10 milligrams or lower equivalent dose. So we do not want to continue to dose immunotherapy while you are on higher doses of steroids, because we're kind of working against each other, trying to calm the immune system down on one hand and activate it. So we may just be exposing you to toxicity. But getting and treating for a toxicity and then having that resolve does not necessarily take away from the efficacy of what you've already had. We've certainly seen patients that we've given 1 or 2 doses of therapy to have had a robust response, required prolonged steroid tapers, and go on to have wonderful responses to immunotherapy in the absence of continued dosing of immunotherapy.
Okay, thank you. So it does not take away the efficacy.
Correct.
If we're managing an autoimmune breakthrough event. There's a question about, it looks like Checkmate 067 continues its success 7.5 years later. Is there any information available on stage 4 patients dealing with side effects, IMARS, the immune-related side effects, and post 5 years treatment with Nivo AP, particularly those treated with brain metastasis and have been treated surgically with radiation? Is there any research looking at this? So the long-term toxicity data is collected, but remember, the median survival with somebody with brain metastasis in melanoma used to be in the range of 2 to 5 months. And, you know, when folks are out 7.5 years and they've had brain metastasis, they've had insult to the brain in multiple forms, one with the metastasis themselves, and then potentially with surgery or radiation, and then immunotherapy. We've seen post-immunotherapy, especially about 18 months or 2 years kind of time frame, folks who are doing okay otherwise develop the phenomena of radionecrosis that was not previously quite appreciated as much because, you know, the survival was not there. So I think that data is being collected, and yes, so with CNS involvement, some of the toxicities are not reversible. Some of the toxicities that happen with immunotherapy are not reversible. So if there are endocrinopathies that Dr. Atlas mentioned, if the pituitary is damaged or the thyroid is damaged, the adrenals are damaged, pancreas, you know, those require lifelong management. Those glands do not grow back. So it is being looked at, but some of these will not be reversible. I think we're at time, but there are a couple of other questions. Maybe we can take one more, Anne? Or how many can we take?
AIM will continue to live stream for as long as there are questions you would like to answer live.
Let's see. So there is a question about, is amelanotic melanoma always related to UV exposure? And does that mean if you get subsequent melanomas, they will be amelanotic as well? Dr. Atlas, you want to take that?
It does not mean that just because you had an amelanotic melanoma that future melanomas that you have will also be amelanotic. So that answers that part of the question. Sorry, what was the first part of the question again?
Is it always related to UV exposure?
The vast majority of them are related to UV exposure, but there are melanomas that have, you know, other targetable kind of pathways that can sometimes be mutated that can lead to it. So certainly kind of hereditary genetic predisposition can be part of it, but UV exposure is the most common reason. Anything you'd like to add, Dr. Amin?
Yeah, I mean, the only thing is sometimes the amelanotic melanomas are usually what we see in terms of what are in transit metastasis. So they may not really be primary lesions, but there may be recurrences or lesions that appear close to the primary that lack pigment. So there is no a significant amount of information if they act any different from the pigmented cutaneous melanomas. So we would like to get more information on that. There is a question about I've been diagnosed with spitzoid, and information about this type is very minimal. How is it substantially different from other melanomas? So this is a phenotype, or this is a kind where it's essentially described by the pathologic features of these cells. It's more common in the younger or the pediatric population, and they generally behave a little less aggressively than cutaneous melanomas. Some of them can metastasize to the local lymph nodes, but we don't know if all of these folks with spitzoid melanomas really require immunotherapy or adjuvant treatment. Dr. Atlas, why is melanoma so aggressive?
We can see a vast variety of situations. Some melanomas can be more indolent and be something that has, progressed or changed over long periods of time. There are a number of different mutations that lead to the development of melanoma, and a number of features that can lead to kind of more aggressive features. Melanoma is particularly tricky and difficult for a lot of reasons that Dr. Amin kind of described in our roadmap system. It has a lot of different ways it can spread. So kind of using kind of that neighborhood kind of spread of in transit, our lymphatics, using our blood to travel kind of as a highway system. So it can make it very difficult to treat. And, thankfully, in more recent years, we've had the development of some medications that have improved upon what we can do with immunotherapy and targeted therapy. But the answer is there's a lot of mutations. They're highly mutated cancers. So we're having to try to target many different pathways. And sometimes when we shut down one pathway, it finds a way around to another pathway to continue to grow.
Yeah, so generally the aggressive nature is a measure of how rapidly these cells travel elsewhere. And so even within the cutaneous malignancies, there's a spectrum of this aggression. Cells that are in the basal cell layer make basal cell carcinomas, and they almost never travel elsewhere. They're usually locally invasive. And then the other end of the spectrum are the melanomas and the Merkel cell carcinomas that have a very high propensity to travel. And then somewhere in the middle of that spectrum are the squamous cell carcinoma, that is another cell in the skin that can travel but doesn't travel as often as the melanomas or the Merkel cell carcinomas. So it's the aggression comes from their propensity to travel. There is another question. If you're younger, when you're diagnosed with melanoma, is that more dangerous, or does it have a worse prognosis long term? As we said, the younger phenotype generally is a little bit more favorable. That's the spitzoid kind of melanomas. They generally do all right for and do not have very aggressive clinical courses. But yes, it would depend on what is the melanoma, what kind of melanoma was it, and that is going to be what is more important rather than the absolute age. So I think that those were all the questions that I saw that had not been answered previously. And I think we are at time. So I thank everybody again for presenting. I thank AMED Melanoma for inviting us to participate in this activity. And if there are other questions, we will remain available. So thank you all. And anything?
No, just thank you so much to all of our panelists today. Your presentations were absolutely excellent. For those people who put in questions that didn't get answered, I would direct you again to our website and to our Talk to a Medical Expert. Perhaps Melissa would be able to answer some of those questions for you. Thank you again. I hope everyone has a wonderful day. And thank you, Atrium Health and Levine Cancer.
Okay.
Bye-bye.